Welcome everyone to today's webinar, The Future of Healthcare, Revenue Cycle Management Strategies for the New Normal, sponsored by Cognizant. I am Ayla Ellison with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can use the same, you can submit questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We look forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. It is now my pleasure to introduce today's presenters. Srinivas Srinivasan is a director in Cognizant's consulting provider practice and leads the group's revenue cycle management sub-practice. Srinivas' expertise covers the healthcare continuum in the provider and payer markets, as well as RCM business operations. He has prior professional experience in healthcare operations and management consulting. Ruchi Mishra is a senior manager in Cognizant Consulting's provider practice and is the operations lead for the revenue cycle management service line. She has deep RCM expertise across hospitals, retail pharmacies, and DME providers. Her healthcare expertise includes working with providers, payers, pharmacy benefit managers, and retail pharmacies. At this time, I am pleased to turn the floor over to Srinivas to begin today's presentation.
Good afternoon, everybody. Thank you, Ella. If you can please go to the next slide. So what are we going to talk about today? We'll give you a brief overview of Cognizant Healthcare. We will set the business context of what is RCM going through today as far as operations are concerned, as far as COVID-19 is concerned. We'll talk about new paradigms for RCM. What does RCM need to do given everything that's going on right now, what's gone on, and what's going to happen potentially in the future. And that leads us to talking about digital RCM, the future of RCM, and how we look at it and strategize about it in a sort of three-phased approach of optimize, innovate, and disrupt. And yes, RCM is going to get disrupted. Next slide, please. Sorry, just want to give a quick overview to folks who don't know much about Cognizant and Cognizant Healthcare. We are a $4 billion line of business within the Cognizant entity of $16 billion. From a healthcare perspective and from a provider perspective, we touch about 200 million lives and handle about 2.5 billion transactions a year. We have about 300 plus health systems, 350K providers, and about 400 practice management and EMR partners. So we are very familiar with the provider space. We play in the payer and in the PBM space, and 3 out of the 5 PBMs and 16 out of the top 20 healthcare plans are supported by, in one way, shape, or form, by Cognizant. So we do understand healthcare. Next slide, please. So this talks to the overall, healthcare provider market and the entire set end-to-end operations. This is area which we are all very familiar with. What we really want to show you is where we participate, where we play, and where we can help you. Today's focus is clearly digital RCM and RCM solutions. That's our area of focus. But overall, we're very comfortable with the provider space, and we can provide services, solutions, and capabilities across all of them. Next slide, please. So to set the business context, thank you. So this is a quote from a colleague of mine, Peter Borden. Yes, COVID-19 is an unfortunate event. It is a force catalyst, and the impact it's having both on healthcare operations, RCM in specific, and society at large. Some of these changes are permanent. Some of these are very significant. Some of these are unwanted, but at this point, we don't have a choice. We have to keep moving forward to ensure that we are well positioned to deal with what's going on. The reality of it's here to stay, and we have to deal with it. Next slide, please. For those of us who are in the RCM operation space, we're dealing with these numbers at an individual level. The number that sort of really threw me off was the expected losses are expected to be anywhere close to 320 billion by the end of this year. That is a tremendous loss which cannot be recouped in any point or shape anytime in the near future. So we are definitely dealing with a scenario where we are looking at a situation which is clearly not normal. It's beyond new normal. It's established a level of a level of operations which have to be sustained in a completely different way. So if you look at the financial implications, services are curtailed, opportunities are curtailed, revenues are curtailed, reimbursement is a problem. Payers are having difficulty, providers are having difficulty, employees are losing their jobs and cannot pay for their insurance. Net, a really complicated and a really convoluted financial situation which has to be dealt with. Next slide, please. So this is a quick overview of how we look at the RCM value chain. There are three areas we try to focus on, and I've got a detailed version of this. But the three areas are patient access, the point of getting to see patients, getting patients, scheduling them, taking care of their pre-visits, during the visit. Then the care to claim, the care has been delivered, claim has to be generated, ultimately claim to payment. This is a very simplistic view of the operations, but I just want to set the table here so that when we go into details, it'll be a little more helpful. Next slide, please. So this is our value chain, and this value chain looks, we're all familiar with this. We all are very comfortable with this. The focus is not on the specific terms or terminology that we're using. What we're trying to highlight here is COVID-19 has impacted front, mid, and back office. So if you look at it from front office to from scheduling to all the way to financial management, where we record it in our financial systems, the problem areas are several. What we've highlighted are typical areas of concern. It doesn't mean that every one of you has the same areas, depending on the maturity of your organization and where you are in your organization journey and operational optimization within RCM. Your impact may be different. For us, the key point is, depending on where you are and how you're doing business today, you still are impacted. And if you have front office impact, then you're definitely going to see it's cascading impact in back office, mid office, and then ultimately back office. If scheduling is impacted, if patient appointment is patient pay is impacted up front, you're definitely going to have issues with denials. You're going to have issues with collections. You're going to have issues with cost to collect. Bottom line is operations are affected, and as I said earlier, some are affected way more than before, some are affected permanently, but the bottom line is they're all affected. Next slide, please. This is our view of what it's going to take to get to steady state, right? I want to emphasize a few things here. One is there's a difference between opening for business, you're already open for business, you're running, and normal patient volume. Those two are two clearly different business events. The second is, please don't lay too much emphasis on the specific slope of the graph that we've shown here. So if you look at it, the blue is best case scenario, green is the blue is the best case, the green is most likely, and the red is worst case. Two things we want to emphasize here. Don't worry about the slope of the graph. It is what it is. It is based on what we've seen so far, based on our analysis, based on our read of the market. Yours may be slightly different, or you may be ahead of the curve. The point we really want to emphasize is there is a fair amount of uncertainty to which you cannot, be immune to. You have to react to it, and there is a certain amount of uncertainty which you cannot do anything about. So be aware of both. The second aspect of it is that this is going to be unpredictable. It's going to be very hard for individuals, organizations, analyst companies, or anybody to say with any degree of certainty to say this is exactly how it's going to pan out. I wish I knew the answer. I'd be happy to share it with you, but it's not the case. So it's very difficult for anybody to predict. The uncertainty, the sinusoidal nature of what's going to happen, and the unpredictability is going to affect what happens. You're open for business. There is a certain sense of, where people have said, telehealth has taken up. Yes, but people are seeing drops in the volumes for telehealth because a certain segment of the population, especially the senior citizen, are reacting to telehealth and saying, no, we prefer the personalized visit. So the uncertainty going forward is going to make things difficult. But the point of our hope, our exercise is to show you some options, some opportunities, some opportunity spaces, some options, and some focus areas where you can look at and say, yeah, despite all of this that's going on, here's what's going to happen. Keep in mind, we could be dealing with another unfortunate event of any kind, pandemic, social, political, global event. And what we've seen is an impact to any part of the globe. Now we're so interconnected, is going to affect every part of the globe. At this point, I want to transition to my colleague Ruchi to start talking to you about the new paradigm in RCM and how we get to it.
Thank you, Shravat. Hello, everyone, and good afternoon. This is Ruchi Mishra, and as Shravat pointed out, I look forward to sharing some key emerging trends and how you can prepare for this new normal. Clearly, providers are facing some serious challenges with COVID-19, both operationally and financially. So, look forward to presenting that to you. So, this slide will talk a little bit about the overall key trends and associated RCM challenges that have emerged due to COVID-19 pandemic. Some of these trends existed before, but what we are seeing is COVID-19 is acting as a catalyst for long-lasting RCM impacts. Starting with revenue loss, it's a key trend, and we see a decline in elective surgeries, patient volumes overall. Unemployment has and will continue to result in increased Medicaid beneficiaries who are reimbursed at a lower rate than commercial. And in longer run, there are concerns about lowering reimbursement rate for telehealth, as it becomes more mainstream. Additionally, with around patient payments, we see that patients' ability to pay has been severely impacted due to loss of employer sponsored health plans, loss of jobs. So it is imperative to collect the most current insurance information and reperform eligibility checks every time a patient visits to ensure the providers have the latest information, and also leveraging that information to offer specific payment plans as appropriate to patients. Virtual care, and I think we are all aware, and there has been a push in past, but with COVID-19, there's been a significant move towards virtual care delivery that requires additional assistance and attention towards robust clinical documentation, accurate reimbursement of services, and ensuring that there are prevention of denials as we offer these virtual care services. A lot of providers are not technologically equipped to continue telehealth based delivery, and we believe that that's something that needs to be focused upon. Last but not the least, the staffing dynamics have been impacted across revenue cycle management, front, mid, and back office, especially because RCM staff in past have not operated remotely. They've relied on manual spreadsheets to manage workflow. So we see that presenting those as a solution is a key impact of COVID-19 that we are seeing within RCM. Next slide, please. Looking at these specific trends, what we want to share here are some areas of focus. Now, overall, these are some focus areas where you as provider can address the immediate short-term impacts, and also can plan for the longer-term impacts of COVID-19. And looking at this point, you should look at these areas of focus. RCM diagnostics, virtual care enablement, digital enablement, and end-to-end managed services. We believe at this point you should have initiatives within each of these areas. And what's critical to be successful as we plan for the future is to make sure you have success criteria defined for each of these areas. For example, RCM diagnostics, I think, assess your operations, and everyone's operations is different, but identify what are some quality benchmarks, and we have identified some metrics, days in AR, for that. But assess yourself against the benchmark and see what should be your area of focus, within your RCM operations. In terms of virtual care enablement, I think the world is moving towards the work from anywhere model. But what's critical is to be, as you offer the flexibility to the RCM staff, it's critical that they are able to perform jobs from anywhere, but also from a coding and billing standpoint, that you have accurate systems and checks and balances in place to make sure there are no denials because of because of telehealth visits. And creating an infrastructure which is focused with basis on digital is important And flexible staffing models is where we see, we are all moving to. And it's critical that there are AI-based workflow management to make sure that your staff is actually focused on areas, that are priority from operational standpoint and from financial standpoint, and ensuring that you have an AI-based workflow model that supports, dynamic staffing and priority-based operations. So, definitely what you're seeing here are representative samples, but you should choose, whichever work best for your organization, and then define success metrics accordingly. Next slide, please. We did share some focus areas, and what you're seeing here is, one recommended approach. Again, there are different priorities, as I mentioned, for your organizations. Front office could be priority, or back office, denial could be priority. But how to achieve what we mentioned in the previous slide is, for you to ensure and operationalize, to ensure that you're trending in the right direction. So select the approach that works best. Like I pointed out, analyze your operations and define your success criteria. Evaluate which are your areas of focus in the next 3 to 6 months, and then in the longer term transformation paradise. I would like to point out reinvention is the key word here, and and as we have seen over the last 6 months of COVID, organizations cannot continue with what they are doing right now. Most hospitals cannot go through another cycle of this without changing, and it's important to take this as an opportunity and lay the foundation for immediate future and longer-term future to enable your operation, and then operationalize accordingly. Next slide, please. Great. So we did look at some trends and their impacts, based on COVID-19. In the next section, we'll look at the digital revenue cycle future and our view of the future revenue cycle. So next slide, please. This is what we call it, our revenue cycle, digital revenue cycle wheel. As you'll see, if you start clockwise, it goes from a patient registration, through front office and mid office, claim submission, payment posting to AR and collections. And what we have done here is sort of identified some key areas of opportunity within each function of revenue cycle. And where you see those little gray COVID-19 icons, we feel those are some critical areas that have been impacted because of COVID, and the areas that you should certainly pay attention to, in addition to the other ones. Again, what's important to note is every organization is at a different level of digital revenue cycle maturity. And if you have certain capabilities already, then you have a head start, and you can focus on other transformational areas. So, on the top, you can see patient propensity to pay. We've identified that as a key impact, because of COVID. I think being able to determine the propensity to pay and then presenting the patient responsibility upfront is important, and then presenting the payment plan option to patients is important. So that gives the providers opportunity to collect upfront, but also gives that comfort to patients, to have a payment plan accordingly. We see, across this whole value chain, we believe you can bring in digital levers such as, automation, AI, and machine learning within each function. In some functions, AI could be more valuable versus automation. But as you see, we see opportunities across the value chain: AI-based workflows, AI-based payment posting, ensuring that we have AI-based denial management. So, to be able to predict chances of denial, and then updating the process, from a people standpoint, but also from a overall process and technology standpoint to detect, specific denials before they even go out of the door. So leveraging AI technology to predict denials and then fix for future. So this is our RCM wheel. Definitely want to, you should assess for your organization specific opportunities, but definitely opportunities are at each step of the process. Next slide, please. Moving on, so we talked about areas of focus, what approach you should take, and then overall transformation strategy. The key strategy here, you'll see some near-term opportunities that we have outlined, medium-term and longer-term, which is moving from optimizing to innovating to disrupting. And what's critical is that every step of the way will take you closer to the disrupt, and there is a pathway to RCM disruption. As Srivas pointed out, that there will be disruption in RCM, and here is a pathway, and not each step needs to be sequential. It can happen concurrently, and we have included some examples for near term, like we talked about AI-driven propensity to pay. Medium term, touchless check-in and touchless authorization that Srivas will talk about in future. And in longer term, the goal is to get to touchless pricing, touchless claims adjudication, and touchless reimbursement. That's our hope and goal in the longer term disruption, and but definitely want to present and share with you for you to take away what makes most sense for your organization. Next slide, please. So in the next few sections, we'll talk about the opportunities to optimize, opportunities to innovate, and some examples, and then opportunities to disrupt, and how can what steps you can take to get there. So next slide, please. So these are some guiding principles that we do want to share with you in terms of the near-term focus for you to optimize. In our experience, these are sort of the four guardrails we think you should assess for your organization. And then I would say assign different weights, for each of the areas. So we have, enhanced patient experience, improved productivity, reducing revenue leakage, and then metrics-driven operations. I think all organizations should, strive to excel in each of these areas. But depending on where you are in your journey, if your organization is already strong in customer experience, then you should, assign a stronger, higher weight to, say, reducing revenue leakage, or enhancing and making your operations more metrics driven. So opportunities are in each of these buckets, but you should review and assess what makes most sense. Next slide, please. So in this slide, and again, these are some sample opportunities, I would say, but we have called out some specific use cases that you can review and look at from your organization. So within cash posting, opportunity to make it AI-based payment posting. Within AR, as I pointed out, leveraging past trends and making an AI-based workflow to ensure your staff is working on the most priority, most higher value claims that have high likelihood to be paid. Reducing denial management, doing past capabilities, looking at past denials from specific payers, looking at what makes sense to be worked upon, and then developing a system where you're able to have an automated tool to develop appeals packet as necessary. So these are some areas and use cases that we want to present across the value chain where you can optimize. Again, this is in no way all the use cases, but definitely something for you to get started on and focus on. Next slide, please. In this next section, we'll look at how you should go about innovating and identifying some areas to innovate on, and we'll look at one example. Next slide, please. Great. So we, as healthcare is becoming more and more patient-focused, consumer-focused, we wanted to use this digital patient experience as a use case for us to look at from an innovate standpoint. Again, innovation starts, even before the patient checks in. So pre-check-in through, after the patient has had the treatment, a visit, and through final billing. So we want to walk you through this entire experience, and what's critical here is you can innovate the entire value chain in phases. And we see our clients trying to do too much and do sort of the end-to-end experience. What's important is to assess what are the different areas that need improvement and where you should bring in digital levers, and then innovate in phases. And that's perfectly okay. What's important here is starting from the first step, the patient comes in, making sure that you give them options to schedule, to self-serve, automate authorizations to touchless authorizations. So you have that option for to present to your patients. Like we talked about, I think patient responsibility, upfront patient responsibility, and making sure as a patient they're comfortable coming in and have an estimate of what they'll be paying is important. And again, based on propensity to pay, being able to offer a payment plan is very important. And once the patient comes in, it's important that you, of course, the clinical pieces come in, but giving the patient the option to do omni-channel payment. There are different channels coming in: Google Pay, Apple Pay. But making sure that you present different options to the patient is very important. And last but not the least, and this I think is several of us have patients have faced receiving multiple bills for a visit to maybe the same facility. And what's important here to call out is presenting a customer-friendly unified bill. And what's important to note here is if I had a surgery, a lab work, an X-ray, and some blood work at the same facility, instead of receiving 5 different bills for for my visit to the same facility within the 1 to 2 day time frame, it would be important for us to look at it from a unified standpoint and present one bill to the patient to help with that overall member and patient experience. So, again, customer experience is just one specific use case that we wanted to present, since it's getting more and more important for us to within healthcare from a customer service standpoint. But again, there are different opportunities for you to assess and improvise and innovate within the RCM value chain. So that's all I wanted to present with this. I will pass on to Srivath, my colleague, to talk us through digital revenue cycle disrupt. Thank you. Over to you, Srivath.
Thank you, Ruchi. So, let me just start by saying disruption is going to occur. It's not a choice. It is going to occur, and it's going to occur in massive waves. The better prepared we are, the better we are to receive it, the better off we will be. RCM of the future is going to look different from what we've been used to so far. Next slide, please. So this is our view of where the disruption could originate, could impact, could occur. And these are 6 areas we believe are significantly going to change RCM, either because there is a fair amount of innovation going on in each of these areas, or there's a fair amount of pain points, and so there is a certain level of, that we can, remove friction from these operations. But there are additional areas, but these are the 6 we believe are going to happen. I'll touch on some of these briefly because we're going to go into some depth against some of them, but I'll touch on them briefly for sure. So digital EDI is our vision of what the state clearinghouses of today are going to look like. You will not recognize them the way they are today. They will be black boxes offering a variety of value-added services. The whole point of receiving claims, delivering claims is going to become pretty mundane. Touchless claims, and I would include the whole touchless claims, touchless authorizations, real-time claims, real-time adjudication, real-time reimbursement. The idea we very strongly believe in touchless claims, there is no point in somebody clicking on a claim just to hit OK. Interoperability. I want to emphasize a point here. Interoperability is part of the CMS mandate. CMS is very heavily committed to it, and they have opened the floodgates now. It is going to be next to impossible, if not absolutely impossible, to put the genie back in the bottle. As of Jan 1, 2021, patient data is going to be made available through public APIs. As of Jan 1, 2021, provider directory is going to be made available. A small clarification, enforcement date is July 1 for both of them, but as of now, everybody's shooting for Jan 1. And so interoperability is going to separate winners and losers very clearly. The winners are going to be in companies, organizations which use it to advance their case forward, make them more market relevant, make them more product competitive, not just compliance. Compliance is table stakes. Digital patient experience, and as Ruchi highlighted, it's our belief in the 360-degree view of the patient experience, not just in enabling some piece of it. Yes, I get scheduling messages because I've got a prospective appointment with my clinician or doctor or specialist, but the entire experience, starting from before they enter your facility to when they're there to post, including, yes, unified bill, starting from everything. So all of that is part of the digital patient experience. Virtual care anywhere. This is going to redefine how services are going to be delivered. It is going to become, it already has, some not by choice, but it's also going to affect things across the operational continuum, ranging from clinical care to care delivery to operations to back office to post back office, dealing with the customer. So it's going to take unified approach to deal with this because there is going to be infrastructure needs, there are going to be operational needs, and yes, there are going to be people needs which have to change. Value-based care, we've sort of been waiting for value-based care to happen. It has happened in small way, it has happened in a small scale. It has happened in a way that, very small portions of our customers, our healthcare customers, consumers are affected. It is going to expand, and it is going to expand because ironically, because some of the enablement of interoperability. Value-based care is going to become much easier because data can now move. Data is now liquid. It can move from payer to provider to payer to payer to payer, provider to payer, or any combination thereof. And CMS, as I said earlier, has put mandates and SLAs about it. So value-based care, both the origination of it, the delivery of the care, and yes, the RCM side of it, but it will become a purely transaction-based operation versus having to worry about, what do I do? How do I build this? Do I submit this claim? I submit it, and then I get a denial, or how do I deal with disbursement? All of that will become, will be addressed in some way. So these are 6 areas. There are other areas, but in our belief, these 6 areas will cause disruption in RCM, whether they do it because inherently there are pain points there or because of inflection of new technology. And we'll see some of that in the next few slides. Next slide, please. So this is what we're terming and phrasing as the disruptive RCM architecture. As it stands right now, I want to make it very clear that it is going to be disruptive, and it is going to cause, for organizations that are not ready to take advantage of it, they're going to get left behind is what's going to happen. So if I look at this picture from the left to the right, on the left, we have, what I call clients. The clients could be on either side, by the way. They could be on either side because they are, the clients could be, as I've shown it here, it starts with, with providers and healthcare facilities, but the clients could be payers. So the clients are, in this case, healthcare providers, generate data, generate transactions, which are handled by this interoperability fabric. And we called it a fabric to really speak to it and say it's a fabric. It is going to be seamless interconnection. So let me be very clear about it, right? So I'm talking beyond just technology. I'm talking beyond technology interconnection. I'm talking operational interconnection is going to get seamless. You will be, and I'll give you some examples of how that could happen. And then post that is, so post that I see, what I've called a digital EDI. And digital EDI is going to play a critical role as an intermediary between, say, healthcare providers and payers, performing some of the functions, and we'll see some of the functions like touchless auth, maybe touchless, claims adjudication, or potentially participating in real-time reimbursement. The bottom line is they will help payers and providers complete their business operations. And to the right are the entities which are typically, you see, payers, government entities, commercial payers, and any entity that now is participating, large employers, self-employed groups, any entity that's participating in it. The interoperability fabric in the middle really is the glue that puts it all together. The situation and the experience and the technology is going to look a little different, because previously we looked at point-to-point connection. I connected from my provider facility to the health, to the clearinghouse or to another provider. This is now going to become a mesh. It literally is going to become spaghetti-like, where you can connect between them. And the key point there is operational seamlessness. So if I set up a touchless, if I set up a schedule, potentially in an automated way, touchless auth could be generated and adjudicated, all happening in the background without my knowledge. And we'll show you how that occurs. Next slide, please. So touchless authorizations, this picture really talks to, there is a tremendous amount of financial savings, operational savings from touchless authorizations. The manual effort that we all go through to initiate the authorization, follow up with it, for the payer to respond to it, repeated phone calls, clicks on the link, going to the website, it's a cost differential orders of magnitude. It could be anywhere from, a manual authorization could cost anywhere from $15 to $20 a transaction, versus an automated one could cost less than $2. So there is a business need for it. There is a patient experience need for it. There's a provider experience need for it, because everybody benefits when this occurs. So how does this work? It's pretty simple. The prior authorization could be initiated from a provider. It could be initiated directly from their EMR, from their from their EMR, or it could be, as I said earlier a few minutes ago, it could be automated. Every time a specific type of event is created, and an automated request goes out, it collects the information that is required for a prior authorization, submits it to the prior auth partner. The reason I called it the prior auth partner is potentially could be the partner, or it could be a payer. It doesn't have to be the payer. It could be a partner, and lots of companies like us are offering these capabilities. So that the partner validates that prior auth and adjudicates it and sends a response back in near real time. The idea is to get the information back to the provider and say, okay, here's the response, and the provider benefits from it because they now have the information available immediately. They can explain it to the customer or to the healthcare member and say, yep, we've got the authorization, no follow-up is required. Everybody's clear about what the decision is. Yes, a certain set of prior authorization requires manual process, and those would be directed to the payer teams for medical review and their regular review process. That is going to occur, but a vast majority of them can be done. We have instances where payers are now running 40,000 transactions a month. They started, and in 4 weeks, that's the volume. So there is definitely a tremendous need for it. If you haven't looked at it, if you haven't considered it, please do. Next slide, please. So we put these three together because there's a progression. So real-time pricing, real-time claim adjudication, and ultimately real-time reimbursement. Real-time meaning, yes, the transaction initiated, it's adjudicated, and the response comes back near real-time, or at least as close to real-time. What we said about real-time pricing is beyond just price estimation. It really is to take it a step further and say, here's a request from a provider to take it and really do a pseudo claim adjudication on it and come back with the best and most accurate information available. On this picture, if you look at it, the borderlines are the disruptive RCM transactions, and the dotted lines are the traditional RCM transaction. While the transition is going on from traditional RCM to disruptive RCM. Both parties are needed. So how does this work? The transaction is initiated, for example, for real-time pricing from a provider facility. It goes to the EMR generates it. It goes to digital EDI. Digital EDI recognizes it as, hey, this is a transaction that can be subject to real-time pricing, and says, all right, I can deal with this. Deals with it, deals with the payer, gets the response back, gives it back to the EMR or billing system. And yes, you can do additional things like within the EMR, put it into the right work queue, say, that has to be dealt with. So it's not just automating the transaction, but as I said, using the interoperability fabric to really seamlessly, integrate operations and eliminating wasteful manual steps. Real-time claim adjudication is taking a step further and working with the payer to say, okay, the claim, you've priced it, let's adjudicate it at this point and determine what its status is. If it's going to be targeted for reimbursement, let's notify the provider. If it's going to be denied, let's notify the provider and provide them reasons for it so that they can then affect their operations. And if digital EDI has anything to do with it, we are looking at scenarios where digital EDI can look at and make changes to the business rules within the EMR to ensure that next time this claim goes out, it goes out with the right data, if that's what it requires. Bottom line is real-time claim adjudication is feasible, is doable. If the claim has been adjudicated, there really is no reason why real-time reimbursement cannot or should not work. We see no reason why that should not happen because it's already been, it's been priced. It doesn't have to be priced for adjudication. It's been adjudicated. Let's deal with the real-time reimbursement. And yes, real-time reimbursement can leverage our existing payment channels, automated clearinghouses, lockboxes, and all of it. But it doesn't mean it cannot use newer micropayments, blockchain-based payments, or any of the other. But the value point there is really you can use existing payment channels to do it. So you can go from real-time pricing, real-time adjudication, and ultimately, yes, real-time reimbursement. And some or all of this is occurring right now between various organizations. Some we are part of, some we are observing. Next slide, please. One of the themes you will see here that we've sort of been emphasizing is the aspect of AI within RCM. And yes, AI is going to play a much more significant role within RCM. Not that it hasn't already, it has made a difference. And it is going to play a much more significant role. Within RCM particularly, we have lots of data. We just haven't been able to use it well to really do actionable things with it. So if I have 6 years worth of denials, what can it tell me about how I operate and how my payers are operating? What are the denials that I make a mistake on versus what are the denials which the payers is consistently denying because there is some either issue with the contract, issue with the schedule, or some combination thereof. So the idea really is, okay, we've got all this data. We've got all this data, whether it's patient, clinical, administrative, financial, third-party data that we have. Let's get it through the interoperability fabric, which I touched on earlier, to services, third-party vendors who can then take the data and provide AI as a service. We've had hardware as a service, we've had infrastructure as a service, we are all familiar with software as a service, whether it is using Office 365 or any such solutions that occur. But AI as a service is going to happen. The data lake that receives it, there are models, AI models that we can use, currently we're using and building. And one of the advantages of the machine learning models right now is they're self-learning. So as more data comes in, they learn. They learn and they learn better, and they get better at the insights they are providing. And this is, as I said, it's a service. You don't have to sign, you just have to sign up for the service. You don't have to install infrastructure. You don't have to have a server. You provide the data. You get the actionable insights. They can even poke, as I said, using the interoperability fabric, post it back into your EMR or billing system. What can you do with this at this point? You can look at things like, what Ruchi was saying earlier, patient propensity to pay, payer propensity to pay, denials, a retrospective view, a prospective view of denials, using, social determinants of health to say, does that impact payment? Does that impact, what else can I do to help this member, help this customer get home so that they can, deal with issues so that they can ultimately, the hospital gets paid. Workflow optimizations, Ruchi touched on this, to really use AI to drive what work gets done and why. I don't start operating on the first claim I see because that's easiest, or I pick on a payer that I like versus a payer I don't like. And being able to change that dynamically across the globe because now you're working from anywhere. And yes, touchless claims, any aspect of the claim that can be made touchless, whether it is, and when I say claims, I really mean, anything from authorizations to claim, let's make it touchless. There is no need for manual intervention. Our philosophy on that is machine-driven, human-augmented. So humans touch only those claims that need to be touched. Everything else goes through in an automated way. Next slide, please. This has been something we've been thinking about for some time, but I think COVID has crystallized it. We really need to rethink and reevaluate all our partners, and that's for all of us. We need to really rethink and say, are they a simple question: are they a vendor or a partner? And the difference is, as a partner, we're in it together. Our objectives are similar, our goals are similar, and we sort of jointly understand what are the issues and how we're going to deal with it. We've had a history of having services delivered by vendors. We've had individual services, potentially business functions. We've had managed services. What I'm referring to here, what we're talking about here is beyond that. We really have to rethink partnerships, and here's some reasons why. Let's start with financial implications, which we're all concerned about. Price arbitrage is no longer reason enough for a partner. It has to be more than that. We are able to deliver price arbitrage. We are able to deliver lower costs. But what can you do beyond that? So price arbitrage should now become just table stakes. Keep up thinking about it. Keep wondering about it, because that will come up again. Global footprint. The idea of working from anywhere by our operations, working from our delivery of services by our partners from anywhere. What we've seen is it's just not taking it and moving it to a single location. Having having a situation where it is, being able to support it from depending on the unplanned event, depending on whether it's an unplanned event, global event, how to deal with it across multiple locations. Putting all our ducks in one single location somewhere in the globe is not going to help. So you have to have global footprint that you can switch between as need arises. Yes, to have a hot backup versus a warm backup costs money, and not everybody needs it, not every service needs it, not every part of our RCM operation needs it. But having the flexibility and a defined partnership which says, yes, within 6 hours, I'm going to switch from location A in Europe to somewhere in Far East or Asia, or I'm going to switch from Asia back to near locations in the North American or South American subcontinent. Absolutely, not subcontinent. South American continent, absolutely. Digital RCM, at this point, it is not an option for the future. Digital RCM needs to be imbued in everything you do in some way, shape, or form, whether it's automation, AI, ML, or a combination thereof. It has to be imbued from day one. If your partner is not able to offer that, you really need to ask them why and what is it going to take to get there, because you as an organization cannot survive without it. And yes, healthcare consumer experience. Digital, yes, digital has to be imbued everywhere, but does digital reflect in not just the customer-facing aspects of it, pre-care, during care, but back office? Can they pay? Is there a global, payment channel available? Can they do a swipe versus, having to pay by card? All of that needs to be factored in, and it's sort of save the less for the last. New partnership models. I mean, do you have partners or vendors is what I started off with. Do you have partners who can walk with you, talk with you, and, take the risk with you? Is something you have to look at. If you're not able to get that, you don't have a partner. You really have a vendor. These are some questions you need to think about. Start thinking about them for the next, vendor relationship that you're looking at. Lay this out to them and see what they think. Make it better, but please do adopt some or all of these. Next slide, please. So we're looking at, so we sort of talked to you about a lot of things. So we just want to recap. There are options for, clearly near term, we're still dealing with the remnants of COVID as Ruchi laid out. Assess your RCM functions. Pick an area which is troublesome, small, medium, large. Pick one and see how best you can optimize it, how best you can infuse some technology into it to improve operations, not introducing technology for the sake of technology, but for really improved operations. Work from anywhere is a default model at this point. Really understand what the implications of the infrastructure, people, change management, SLAs and metrics. Do I need to change that? Do I need to upgrade their technology? Do I need to get them 3 monitors? Absolutely. Virtual care is here to stay. How much of it gets virtual? I think, in my opinion, it's going to get wider. So plan for that appropriately, and we need to deal with it. Medium term, look at automation. Look at automation opportunities. Look at leveraging AI to see what you can drive and how. Look at areas which you may not have thought of. Have you thought of patient propensity to pay? Have you thought of payer propensity to pay? Have you looked at the denials and had an AI engine look at it and say, what are the patterns here? What needs to be addressed? Longer term is, RCM operations are going to get disrupted. take a look at your RCM operations and be prepared that it is going to get disrupted. You may not be able to do anything about some of the changes, but you have to deal with them when they happen. It is going to be a transformational experience. It's going to be a transformational experience for your employees. It's going to be a transformation for your partners, and it is going to be a transformation experience for your patients. And when I say employees, I mean clinical, non-clinical, operation, front, mid, back office. Next slide, please. So where are we? So we've talked to you about, what's going on, what's in the future. This really is an opportunity for us to look at and say, what can we do to infuse digital? What can we do to improve our operations? What can we do to lead to better outcomes? It is a tough situation we're all going through. If it was easy, we would all, deal with it in a much different way. We are at a tipping point, and we, as in, specifically RCM operations, we cannot wait for another pandemic, for another unplanned event, for another terrible event for us to change. This is it. This is our opportunity to get to operational utopia. Are we going to get there? Absolutely. Will it take some work? Yes, but we should make our best efforts to get there. Thank you very much. Those were the slides we had for presentation. We're open to questions right now, Ella.
Thank you so much, Srivastava and Ruchi, for that fantastic discussion. We will now begin today's question and answer session. So please submit any questions you have by typing them into the Q&A box you see on your dashboard. And we'll try to get through as many questions as we have time for today. We've already had several questions come throughout your presentation, so we'll go ahead and jump in with those now. And let's see, the first question that was submitted is, what changes are likely or needed at the clearinghouse level to improve RCM at the provider level? And I'll let whoever wants to chime in on that question go ahead and take it.
I'll take it, Ella, first, and then yeah. So I think the unfortunate fact is the clearinghouse in itself is going to go away. We called it digital EDI, may not be the best of names, but it's going to become very different. It is going to become, a sort of a compendium of services that are offered, in which receiving claims, yes, and submitting claims to the payer is going to be a small aspect of it, but they will become part of the interoperability fabric that we were talking about. They will offer services such as doing some of the touchless authorizations, doing some of the, the real-time claims adjudication or real-time pricing. A lot of currently what are, quote unquote, billing capabilities that are sitting inside our EMRs and our billing system, where they are hard, complicated, there's no way to apply new technologies, are going to move absolutely to the digital EDI, which is the clearinghouse of the future. And there, things can be done such as, looking at and saying, what is the payer propensity to pay, not just across your particular organization, but across multiple organizations, and say, is this claim even going to make it? Let me turn around and send it back right away, right? So the clearinghouse of the future is going to be in my opinion, the smallest and least valuable of the activities they perform. They're going to take over functions which are currently being performed by billing. They're going to take over functions which are being performed by payers, because it's easier for the digital EDI of the future to do it. That would be my responsibility.
Thank you so much. And we'll go ahead and move on to the next question now. And this person is asking, do you see many of the AI automation programs coming from the EMR vendor or mostly from third-party systems?
Okay. I'll separate the two here. I'll take automation first and then deal with AI. So automation, it's one of the fallacies of the healthcare world that the EMR vendors want to do a lot for us in operations, and I understand it. They want to provide us a service, and two, as EMR vendors, they want to ensure that they have solutions in various parts of the hospital operations continuum, whether it is back office, mid office, front office, or clinical. But that's not going to be the reality of it. Automation, like anything else, is a technology product. It's software. It takes time and effort, and it has to be sustained. For an EMR vendor to determine whether they want to focus on the automation tool, or whether they want to focus on enhanced capability for the billing model, or, God forbid, CMS has a new compliance mandate, what do we need to do? It's going to be very hard. In my opinion, I think automation needs to come from automation-specific vendors, tools, technologies that do that. And also to take it a step further, automation from generic vendors and, the usual, Blue Prism or UiPath of the world. I think there's going to be a bigger focus on automation coming from vendors who are much more steeped in healthcare and much more steeped in RCM. Vendors who understand, what the underlying technology is and what is the concept of, what do we need to be worried about? Are there repeatable patterns here that I can use? Do I consistently check claims status in the same way? And if so, why? Right? Vendors such as, maybe Waste or we've got a product and Alpha Health, or there are a bunch of vendors in that space. So to me, we need to figure out what each one does well. So that's why I was saying earlier also is EMRs and billing systems are not very good at some things, and they should stop doing those. And the digital EDI of the future is going to do it by choice or otherwise. As far as AI and ML is concerned, now this is going to be a little bit of a difference from what I said earlier for automation. AI and ML, the core technology exists in the space. So there are vendors who are offering AI engines, AI algorithms. I think it is going to take certain insight from healthcare internally within your organizations, looking at data scientists, if you have actuarial people working in your organization, but data scientists to build some of those algorithms, to build some of those machine learning algorithms, because it requires a deep understanding of the data, and deep understanding of the data is not scattered across the industry. It is in pockets. It's typically in healthcare organizations. It's typically in research organizations. So buying a tool is valuable, or go better yet, go AI as a service. Look at opportunities and say, who can you partner with, and say, all right, I have data, you have ML, let's work together to make it better and beneficial for both sides, and we can come into some agreement on that. Ruchi, you want to add something to that?
I think you've covered it in great detail, Srivat. I agree.
Thanks. Next question, Ella.
Yeah, thank you so much. And it looks like we do have time for at least one more question, and maybe two. The next question that came in, I think this is just based on the tools and strategies you were talking about throughout the presentation, but someone was asking, is this for anesthesia as well?
Yes, it is for all of healthcare. There may be reasons why anesthesia is harder than other areas, and I have a little bit of familiarity, so I would say yes. But there is no reason why it should not work for anesthesia. Automation can be applied for anesthesia because I presume you're using some kind of anesthesia, either OR product, EMR product, billing product can be used. And at the end of the day, anesthesia generates data, generates bills, generates claims like any other side of any other function within RCM. So there is really no reason why it cannot be used. Ruchi, over to you.
Totally agree, Srivat. Yes, whatever we have presented applies to, all the different specialties. Again, you can pick and choose what's more relevant and which use cases most apply to your specific specialty. But, completely agree, Srivat, with what you just shared.
Ella, if you have another question, you can answer. Yeah.
Absolutely, and we do have time for one more question, so I want to make sure that we get to it. And this question is, you mentioned several focus areas for RCM as a small physician practice in small hospitals. What areas would you recommend in Q4 2020 and in Q1 2021, and why?
Sure. Ruchi, you want to go first, and then I can like.
Sure. Yeah, happy to. I think what's very important is, like we pointed out, define your approach, analyze what areas are most important for your organization. I think that's critical. But we do want you to, find the buckets which we talked about in one of our slides, which says, is customer service most important to you? Identify, success metrics within those areas. Now, we've also had clients where they think, front office and, mid office is working great. Their pain point is denials. I think identifying those denials and working through those focus areas, for that customer is critical. So I think the important next steps would be, we would say, is analyze and reevaluate, what you need to do for future, keeping in light all the, things that have changed during COVID. Enabling work from anywhere is a priority for everyone, irrespective of the type of organization. I think that's the focus. Being able to, do telemedicine is becoming an imperative. So identifying foundational areas that can support these core functions would be critical, to make sure you are ready for short term and also ready for the longer term impact. Shrivas, feel free to add.
No, I think that's why I would say, patient ability, patient out-of-pocket patient pay. I would say, looking at eligibility and denials. I think those would be three definitely you should look at. If you don't have issues with those, great, spread out. But if you do have issues with those, start with those three for sure.
Thank you so much for breaking that down and sort of what everyone should be looking for, not just in Q4, but going into 2021 as well. That is all the time that we have for today, but I want to once again thank Shrivas and Ruchu for their excellent presentation and thank Cognizant for sponsoring today's webinar. Please enjoy the rest of your day, and we look forward to having you join us for future webinars.
Thank you.